Good evening, everyone. We're going to start very soon. I'm just waiting for everyone to join, and we'll go live straight away. Please keep all your questions in the message and the chat and messages, and I will answer all of them. So basically, the session will be a quick presentation about what is audit, what's research, and what's QIP. Difference between them, how to conduct every type of project successfully, and then will be to answer all your questions. So keep all your questions in the chat and I will go through them all. So I'll share my screen and we'll start the session. I'll just get the camera off. So, okay. So good evening. My name is Mohamed Hashem. I'm a consultant foot and ankle surgeon at UK Northwest London Family Health NHS Trust. And I have a very long history with medical education, quality improvement projects, audits, and research. I'm the audit and research lead in my trust, and I've conducted many projects for the last few years. It's a fantastic idea to be involved in audits and research and quality improvement. Is the way of development, is the way of assessment, is the way of auditing, and the way to know if you are doing well, if you are doing bad, if you're sticking to trust and standards and not. So in simple way, audit, quality improvement, and research all aim for you to improve your service to the patient. We all aim for a very qualified service to our patients, and to reach this, you need to know is what you are doing up to the standards, or you're doing something different than the standards and guidelines. And if you're doing something not following the guidelines or the standards, what shall you do to get this back to standards and guidelines, and how to improve your service? So the first one is a clinical audit. And to understand the audit, you need to understand that most of our clinical practice in all subspecialties, medical subspecialties, is going according to guidelines. There is a lot of guidelines around the world, and some of them are very old, some of them are just recent guidelines. But there is very good established guidelines. On top of them is the post guidelines and the NICE guidelines from UK, the American Academy guidelines from States, and the Australian guidelines from Australia, and the Canadian College guidelines from Canadian Medical Society. These guidelines is basically based on a very extensive research, very robust, well done, well-formed research, which came with a very strong evidence which support certain practice as a standard practice. And these guidelines meant exactly to standardize your practice and make your practice very safe, very efficient, and very qualified. And when you speak about clinical audit, so you speak about comparing what you're doing to the standard or the guidelines. So basically, you must have a standard, you must have a guidelines, and you are comparing what you're doing to these guidelines or to these standards. And this is the idea of clinical audit. So audit, you just reassessing your practice and looking into this practice, is it following the guidelines and standards or not? Very simple procedure. You can run it everywhere in the world, even in very developing countries. It doesn't need any funding, it doesn't need any financial support, doesn't need any technical support. It needs you to understand the idea, and once you understand the idea, it's very easy for you to conduct it. So I've run audits in Egypt, I've run audits in Oman, I've run audits in UK, I've run audits in UK in different stages in my career and in different places. Clinical audit, you shall do it in your home. So you normally do this in your normal day without understanding this is an audit. So basically, if I speak about your normal day, your normal schedule, so if you start your day at 6 a.m., getting breakfast on time, going to school or going to medical school or going to work, and then from work you get lunch at 12, then continue normally after lunch break, and then you go back home at 5. Then 5 you spend some time reading or doing something, and then you have some family time. This is nearly a standard day, and you are day by day looking into making your day as a standard day. And if it's not, you try from time to time to just audit yourself and see what I'm doing wrong. Oh, what do I sleep up to a very late time in the morning? Do I don't go to work on time? Do I have a problem with the traffic? Do I have a problem with my meal times? So actually, you're auditing yourself all the day without understanding that this is an audit. Same idea in the clinical practice. So I'm operating on certain patient by a certain way, and I have to ask myself what I'm doing. Is it according to the guidelines and the standards of practice or not? So it's a process to measure the current clinical practice against established standard. This idea has to be very clear. And why I do that? Firstly, to evaluate the quality of the care I'm giving, to know if my care to the patient is up to the standard or not. Try from myself to adhere to the standard and best practice. So if my practice is not compliant with the standards or the guidelines, I'm aiming to improve my care to go up to the standard or the guidelines. Then to identify the areas of improvement, and easily while you're doing an audit, you're basically looking into certain point to compare it to the standard or the guidelines, but actually you get a lot of associating points which you can improve and make it better. So it's very common that people understand auditing as a form of like supervision or a form of watching what you are doing. It's not that. It's aiming to quality improvement. So it's aiming to improve my work. It's not aiming for blaming anyone. It's not aiming to put anyone in a trouble. It's not against anyone. It's only positive. So I'm doing that to standardize my practice, to improve my care, to understand what is the area of weaknesses, what is the area of strengths, so how can I make the strength points more strong and the weak point improving to be strong. So we are not auditing for any negative reason. It's all positive reasons. To run an audit, you have an audit cycle. So you have firstly to understand what you are doing and identify that the practice you are doing is not up to the standard. Then you identify the standard. You need to find the guidelines for the point you are going to audit. Then you need to collect the data about what you are doing now, about your current practice, and then compare this to the standards. And then once you compare it to the standard, this will reflect, are you compliant to the guidelines or not? If you compliant to the guidelines, that's perfect, and you need to carry on doing this. If you are not compliant with the guidelines, you need to stop and find where is the problem, plan an action to change this, and implement this change. Then once you do that, you need to go and re-audit to ensure that you have improved what needs improvement. So the key steps of the audit cycle is to identify the audit topic. So I need to know what part of my practice I need to audit. Number two, I need to know what the standard, what's the criteria I'm going to benchmark against, or what the criteria I'm assessing against. Then I need to collect the data about my current practice. So I gather all the data about the point I'm auditing. Then I need to analyze this data to know is what I'm doing is compliant or not. And if it's compliant, it's okay. If it's not, I need to know why not. Then once I know why I'm not compliant, I start put a plan to change that, implement this change, and then once I do that, I come and re-audit and to ensure that this audit cycle has ended into change. So I have done what I aimed for. The aim of any clinical audit is to improve patient care. This is our aim in everything we do, is to to give our patient the most qualified, efficient service. So ensure that your clinical practice is up to the standard. Accountability means you encourage the healthcare professional to meet the established guidelines. Data-driven decision. So all the decision you will take is based on the data already you have in your hand. So I'm not following the guidelines in VTE prophylaxis. My problem is I'm not giving this to the patients on time, and I'm not using the mechanical VTE prophylaxis. I need to improve this, so I'll implement this action. So you have data in your hand, and your decision will be based on this data. Then to be cost efficient, so basically you are aiming to optimize your practice, and optimization of practice improves the patient care and at the same time preserve and save your resources. So example for one of the audits we have run. So audits is very easy, very quick. We do more than 60 audits a year. Teams everywhere working in every point. You need just to identify that you have a problem in one of the points, then start to audit to ensure that you're doing what should you do or not. So one of the simple one we have done and has a very impact on the practice in our trust, on our hospital. We have audited our practice in the mechanical VTE. So basically, every patient go to the hospital according to the NICE guidelines. Any surgical patient go to the hospital according to the NICE guidelines should have VTE assessment, venous thromboembolism assessment, and venous thromboembolism prophylaxis mechanically, which could be a TED stocking, could be flow-trons, any form of mechanical VTE prophylaxis. This is the guidelines. Then I start to notice that not every patient in my ward, especially if I've done a hip operation to this patient, has had the VTE, mechanical VTE prophylaxis. So we went there, we collect data, we see if every patient, every surgical patient admitted to the hospital has had VTE, mechanical VTE prophylaxis or not. Then we came to know that we are not compliant with the guidelines because most of our patients doesn't have a mechanical VTE on the operated hip side. Because basically the staff, the nursing staff were worried about the operated hip. They don't want to touch the operated hip. They're worried about dislocating it. So they don't do any mechanical VTE on the operated side, which is not according to the guidelines, because the NICE guideline says that every surgical patient going for an operation admitted to the hospital should have a mechanical VTE prophylaxis. So they don't do that as they are worried to make any problem for the operated hip. So we weren't compliant. So the first cycle of this audit, we done a booster to inform them that we are not compliant and we should be compliant because the guidelines say that every patient should have a mechanical VTE. We run some sessions, some educational session to the nursing staff and the porters. Then we make a sticker to be put in every patient notes. At that time, we were running just paperwork note, not computer system as we do now. So we put a sticker over every patient notes to remember them that this patient had a mechanical VTE or not, and they have to take the box if the patient has a mechanical VTE. And if they don't take the box, then they understand, they have to know that there is a problem in the notes and the patient has to have a mechanical VTE. Then we went again after 3 months, we reassessed the situation and we found that we start to be compliant with the NICE guidelines. The use of mechanical VTE prophylaxis on operated side has improved. They now use mechanical VTE on most of the patients, but we still not 100% compliant. That's why we went for the second cycle. We applied, the change at that time was to have this VTE prophylaxis from the emergency department. So the patient, once the patient comes to the emergency department from the route, he should have a mechanical VTE prophylaxis. So when he go to the ward, he definitely have. And the same from the operative theater. And with that, we have sent an emails. We have spoken about this in a lot of meetings. So the practice start to improve, and we end after the second cycle that we are 100% compliant to the NICE guidelines. All our patient has a mechanical VTE prophylaxis done for them. So all our patients are safe. Before this audit, we have 2 cases died because of VTE events, so DVT or PE or something like that. And after the audit, after this 2 cycles audit, this has decreased a lot, and we become compliant with the NICE guidelines. So mechanical VTE, our standard was the NICE guidelines. We checked what we are doing compared to the NICE guidelines, and we found that we are not compliant. We planned a change, which is a poster and educational session to the nursing staff. Then we re-audited in 6 months, in 3 months, in another cycle in 6 months, and we found that we have at the first cycle we improved about 70%, and by the second cycle we are 100% compliant with the NICE guidelines. So before I go to the quality improvement, is the idea of audit clear, or do you have any questions? Yeah, it's recorded. يوسف بس خلينا تشيك هل كل الناس عرب ولا لا، عشان يعني ما نتكلمش بالعربي فالناس ما guys, so any non-Arabic, could you just let me know in the chat, because the guys are asking for it to be in Arabic, and I don't want anyone to be inconvenient with the Arabic. Are we all Arabs? Please, if non-Arabic speaker, just to put in the chat that he needs a lecture fully in English. I think we have some non-Arabs. This meaning non-Arab names. Okay, so a lot of people non-Arabic. So Yusuf, I have to go in Arabic, and yeah, I'll be very slow, and I'll try to be very clear. But till this point, anyone has a question about the audit idea, about the audit cycle, or everyone understand this well? Okay, I'll suppose that everyone understands it. Good. So the second one is the quality improvement project. And the difference between the audit and quality improvement is quality improvement, you don't need to have a standard. So both of them aim to improve the patient care, both of them aim to a qualified service, both of them aim to save your resources. But the difference between audit and quality improvement projects is audit, you must have a standard. You are not checking your practice absolutely. You check your practice against guidelines, against standard. So with the audit, you must have a standard. But with the quality improvement, you don't need to have a standard. So in the quality improvement, you just go through a systematic approach to improve the healthcare services. You try to identify your problems, implement solutions, and try to evaluate the impact of these solutions. So basically, audit, you're just comparing what you do to the standard. We don't care what you're doing, this is right or wrong. We care that it is according to the standard. But with the quality improvement, no. With quality improvement, you run through what you're doing. You need to check if if you are doing this is satisfactory, achieving what you aim for or not, and if not, why it's not achieving, and then you start improve it. The purpose again is to enhance the service delivery, improve your clinical outcomes, and foster a culture of continuous improvement. So the aim from the quality improvement to continue improving, and whatever you are doing, you try to do it better. You try to do it better. You try to do it better. So every time you try to go check what you are doing, try to find how to do it better, how to do it more efficient, how to do it more easier, and you do. In the quality improvement, the cycle is you assess what you are doing, analyze what you found in the assessment, come with the changes you want to do to improve your service, implement these changes, and then you're done. So the key steps is to identify. So go through what you are doing systematically. So if I want, for example, if I want to do a quality, we are doing a quality improvement now about documentation in the emergency department. So basically, we look into the documentation in the emergency department for all the emergent orthopedic cases. And we check the documentation, and we found that not all the documentation is clear. Some of the juniors just write 2-3 words. Some of the juniors write 5-6 pages of writing. Some of them comment on every point. Some of them do not comment on every point. So the documentation is not coherent, is not systematic, and sometimes it's not clear. So we went and try to standardize the documentation in our trust. So we make a smart phrase for everyone. So smart phrase is a way to is like a format or template. So everyone see an emergent orthopedic case in the emergency, he use one of the templates and fill in this template, what we call Performa. So Performa basically I give you. So and any one of you can apply this anywhere. So if you want to standardize the documentation about a point, you go to this point and see how is your documentation. So every junior is in the emergency department document in a different way, and we found that the documentation isn't the best. Sometimes you couldn't understand what he did or he or she did right. Sometimes it's not all the data there. Sometimes we feel you couldn't understand where is the problem. So what we do, we make a template like what should he, if he see a patient with compartment syndrome, what shall we write? History, examination, investigation, plan, and we make a standard template. And every junior in the emergency department, when he see a compartment syndrome case, he use a template we put. He just fill in the template, and so all the documentation for the emergency cases in the emergency department from orthopedic side will be standardized in a one way of documentation. And this has improved a lot, the documentation, the understanding, and after that, the management of the patient. Very simple. We didn't look in a standard. We look into making our documentation very clear, very easy, understandable, have all the information. So we went into the emergency department documentation from our juniors, assess the problem, set an objective to improve this and make our documentation standardized, design a plan to apply this, which is the template, and we agreed on the template, and then start to implement this template and ask all the juniors to use it to make the documentation for the emergency cases in orthopedics very clear. Then we went again, reassess and ensure that already all the juniors are using the template we bought, and the documentation has already improved. And based on that, we reevaluate. And again, after 3 months, we did reevaluate again. And we come to say that we have improved our documentation in the emergency department. Now we have a standardized orthopedic documentation for all the emergent orthopedic cases in the emergency department. Another example, so we run a quality improvement project about did not attend in the clinic. So if the patient is booked for a clinic and he doesn't attend the clinic, we call it DNA patient, a patient who did not attend the clinic. And at some point, we noticed that is a lot of DNA patients in the clinics, and the number is increasing that we normally see. We normally see about 5 to 6% of the clinic patients do not attend. So if you have like a 50 patient in the clinic, you may find that 2 or 3 of them did not attend. At some point, we felt that the DNA is increasing. So from 50 patients, 7, 8 did not attend. So we went into this point, evaluate why these patients do not attend, assess the clinics which they don't attend in, collect data about them. Is it the first time? Have they didn't attend before? In which clinic? Is it a fracture or elective clinic? And this patient is a new patient or a follow-up patient. And after collecting all this, we called the patient over phone, asking them why they did not attend, tracing what are the causes of not attending, ask them if they have a communication from our side or not, and ask them how they want us to communicate them efficiently for them not to do that again and attend all the clinics. And we came to know that we have a problem with the communication. So the patient doesn't receive the text messages or the calls we give them to remind them with the appointment. We found that we have a problem with the transportation. So they book an ambulance to get them to the hospital, and sometimes the ambulance doesn't go. So we worked in both of them. We spoke to the booking office. We implemented an application on the mobile called My Friendly app for the patient to remember the patient with the appointment. We spoke to the transportation office to make an easy booking for the transportation for them. And based on that, the rate of DNA in the clinic has improved. And now the patients who do not attend the clinic are less than 2%. So the main difference between the audit and QIP is the audit is measuring your practice against a standard, not about your practice alone. We don't look into are you doing well or you're doing bad. We look into are you following the standards or the guidelines or not. But the QIP not. It's a continuous improvement process. You go, you check what you are doing, you ensure that you are doing is it perfect or not, and if it's not perfect, why it's not, and plan to make it perfect. So NHS, as one of the best health services in the world, they have clear guidelines for audit and QIP. They have a lot of institutions which are working on this only. The Care Quality Commission, which is the CQC, the National Institute of Health and Care Excellence, NICE guideline, NICE, which put the guidelines, the quality accounts, and every trust and every department has a quality and audit lead, which works with all the department and the team to do a continuous auditing projects, continuous quality improvement projects to ensure that we are doing a safe, efficient, effective, will be best qualified service to our patients. So the best practice is to involve the whole team. So it doesn't go just to seniors or juniors. No, you have to audit the whole team. You have to have a structured approach. So how to register your audit? You have an audit and the quality team which look into the project, ensure that this project hasn't been done before. So we sure that this project will add something to the service. Then we guide the people how to do that. We give them the help. We ensure that they implement the change they come out, and they monitor their progress. And definitely we try them to share the results with all the concerned department to just spread the word and everyone to offer the patient a qualified service. The next part of the talk is about the clinical research, and the clinical research is a totally different idea. Yes, it is a quality improvement project. Yes, it's a quality project. Yes, it aims to the same aim, which is improving the patient services, improving the quality of the service, save the resources and the efforts. But the clinical research is basically to implement something new. So with the clinical research, you're trying to find a new way of treatment, a new way of investigation, a new way of doing things. So inventing or introducing something new, this is the clinical research. Clinical research could be observational, so you just look at what the people doing, retrospective or prospective, to ensure to see how they practice. So basically, I'm looking into all the patients who had lung cancer to understand what is the relation between smoking and lung cancer. So I come and look into all the patients who had lung cancer and check who are a smoker from them. And from this, I come with an assumption or result saying that smoking is associated with lung cancer. So next time, if I'm a lung cancer clinic, I will counsel my patient that we found that all the patients with lung cancer are a smoker. So smoking is closely associated with lung cancer. So you have to stop smoking. A very simple example. So observational means you just look into what you found and try to come with an assumption or a message. Interventional, no, you try to implement something new. So you use like a new technique, a new surgery, a new drug, and you see how's your new surgery or new drug or new way of management will make an effect. Will it be okay? Will it be bad? Will it give good results? Will it be safe? Will it be dangerous? So interventional is how you implement something new treatment, new investigation, whatever, and you try to find is the thing that the new treatment or the new intervention you implemented is doing well or not. So that now that all the decision making is based on what we call evidence-based medicine. There is no any more expert decision. There is no any more just simple trials in vitro. All now has to be based on all the clinical practice, all the decision making, all the operations, all the intervention, all the drugs should be based on an evidence-based medicine. And evidence-based medicine goes from as you see, it's a pyramid. It's come from the ground part, which is the lowest evidence with the lowest quality evidence, which are expert opinion, and like you're doing a word round and you go with what the senior or the consultant says or the professor says, if even without know what is the evidence behind that, that is the poorest way of practicing, because it depends on one only decision, which is always mistaken. Or you depend on non-human studies, like in vitro studies. The level above this, or the better evidence, is based on observational study. So you don't intervene, you don't put anything in you, you don't invest anything in you. You just observe what's happening, either prospective. So prospective means from now onward, or retrospective, from now backward. So either you look in the back or you look in the front. But you, at the end of the day, you still just observing, and you document what you observe, and you come with your observations. The level above this in the evidence is the intervention studies, to run a randomized control trial or run a clinical trial. So basically, you try to implement a new drug or a new treatment or a new surgical technique, and you try to see if this is safe and effective or not. The highest level of evidence is meta-analysis and systematic review, because basically systematic review and meta-analysis, they assess a lot of intervention studies together to come with a conclusion. So with a systematic review or a meta-analysis, you come to a good quality projects or studies. You collect all the data from all of them, and you come with a message from all of them. And this message is based on a lot of intervention studies, so it is always a strong and a good message. So observational either is descriptive or analytic. So descriptive, you basically have a look what's happening and you describe what you see. Like if you do a case series, like basically every patient come to me with an ankle fracture, I fix them with a plate and screw. Then after a year of doing this, I ask one engineers to look into all the cases of done an open reduction internal fixation of their ankle, and to come to me to show me the x-rays, ensure that has all of them united or not, and any of these patients has a problem or not. What I did, just observation. I didn't do anything. And the case series will come to say, oh, yeah, you have operated 100 patients of ankle fracture with fixation. All of them are doing well. They have been united. All of them are functionally okay. So I publish a paper saying that fixing ankle fracture with plate and screw is a safe and effective method of management of ankle fracture based on my case series. This is what's meant by descriptive. Analytic means I have a look what's happening, and then I analyze this. So to analyze this, you have three types of studies. Cross-section study means you do a study on a large number of patients at the same time. So like we did in COVID. So in COVID, we did a cross-section study, like, oh, we have vaccinated everyone. So you look into all the patients vaccinated to see if the vaccine has a problem or not. Cohort study, so basically, in the cohort study, you have a result and you go and assess the input. So as the example of lung cancer, so cohort study, cohort means group of patients. So if I want to run a cohort study about lung carcinoma, so I will go to a cohort of patient who has a lung carcinoma already, and then go back and look how the smoking was there, or how certain type of treatment, how is it more in female, is more in male, is it more in rural areas, it's more in cities, is it more in developed countries, it's more in developing countries. So I do an analytic study, but it's still observational. I just go to a cohort of patient which is lung carcinoma patient, and I go back and look into the causes which cause the lung carcinoma. See how is the lung carcinoma is more common. Is it common in male or female? Is it common in this age, a certain age? And this is how I do a cohort study. The other way of cohort study is the case control. For the case control, you basically look into the smokers to see how many of them will get a lung cancer. So the difference between the cohort and the case control, the cohort start from the result and look into the causes. But the case control starts with the causes and looks how will be the results. I hope you got that. So both of them are observational study. Both of them will analyze this observation. The difference between the cross-section means I do a study now on a number of patients now. I don't look in the back or look in the forward. I just go now, see all the patients vaccinated with COVID vaccine, see if any of them get a heart attack or not. This is a cross-section study. And this is mainly come with the prevalence with incidence of diseases. Case control study, basically I go to the smoker people and follow them up to see if every smoker will get a lung cancer or not. And if not, who gets, who not. Cohort study is the other way around. I start with the people who already have a lung cancer, and I go back to check if they were a smoker or not. And I can, from cohort study, say that patients who are smokers are more prevalent to have a lung carcinoma. But in the quiz control, what I will say that 80% of the smokers will get a lung cancer. I hope this difference is clear. So as you see, it's just observational. You don't do any intervention. You just sit and watch. And what you can see, either you just mention what you have seen as a case series, or you analyze what you have seen, which is the observational cohort, case control, or cross-sectional studies. The other hand of it is the interventional studies. So you have to intervene something, you have to do something. So you randomly assign patient into two groups, group with the treatment number A and group with the treatment number B. So like if we're trying to treat pain with vitamin C. So I will go to a patient with, make it much easier. So if you want to look into, if vitamin C will take the regional pain away or not, you get the patient with regional pain, you assign them to randomly into two groups. Group number A, which will receive vitamin C, and group number B or group B, which will not receive vitamin C. And then you follow them up for a certain period of time, and then you come to say, has the patient with vitamin C has been improvement than the patient who didn't have vitamin C? And based on that, I can see that vitamin C will reduce the regional pain. Again, I have patient with regional pain. I have patient, make it easy, I have patient with ankle fracture who had a fixation. So all my patients are ankle fracture patient who had fixation with bait and screw. I will assign them into two groups, group number A and group number B. Group number A, I will ask them to put weight, to walk on foot, which is operated in 2 weeks. Group B, I will ask them not to walk on the foot, which is operated for 6 weeks. Group B is my control group because that is the normal. The normal, most of the surgeon doesn't ask their patient to walk before 6 weeks. Then I will keep them for a long time, so a year or two, and then I will check who are the patient who has failure of fixation, who are the patient who are more in pain, who are the patient who are not doing well in each group. And I will compare both groups. So imagine I find that the patient who are walking in 2 weeks are doing the same regarding the X-ray, regarding the fixation, regarding the pain, as the one who are non-weight bearing for 6 weeks. So I will come with a conclusion to say, no, all our patients can walk from 2 weeks because walking from 2 weeks doesn't have any problems compared to walking after 6 weeks. So no need to keep the patient for 4 weeks non-weight bearing. So all our patients can weight bear based on our study. Patients, as you see, group of patients have the same characteristic. I randomize them, put them into two groups, apply an intervention in one group from them, and the other group doesn't have the intervention as a control group, and then to come to assess the outcome and see if the outcome is more in the tested group than the control group. So my treatment has done a job. If not, so my treatment hasn't done a job. And as you see, it's basically the trials, the clinical trials, is the way how we change the practice, the way how we change the knowledge. So we start, if you go, any one of you, according to the specialties, even the medical school, the ideas and the operations and the treatments we are teaching you now wasn't there 100 years ago. So every 5-6 years, the knowledge is evolving, the knowledge is changing. What I have been taught in the medical school is totally different than what you've been taught now. Why? Because of the clinical trials. Clinical trials, it changes the practice every day. We start by all the Achilles tendon rupture, we operate all of them. Then the clinical trial came to say no, patient can be treated non-operatively. Then the new clinical trials came to say no, the patient can be treated non-operatively but with functional rehabilitation. And the clinical trials came to say, no, now you can operate on this patient, you can do non-operative on this patient. So the knowledge is evolving, the science is evolving based on a clinical trials. So if you want to run a clinical trial, which is a very high level of research. And if you work as a research fellow, if you like researching, if you like it changing the future, and you want to set up a clinical study, is very, very easy. It's not difficult, but the difference is that clinical trial will need a lot of people to be involved. They will need some funding, need some money. So you can do it through one of the clinical research centers. You have to identify a problem. You don't do clinical research for clinical research. You do clinical research to solve a problem or to improve a service you are doing. So you have to identify the service who needs improvement or the problem you have. You have to put a question for yourself, which is we call the BICO question. BICO means B means patient. You identify the patient you are looking into. I means intervention. C means comparison or control, and O means outcome. So you have a problem. I have a problem about shall I ask my patient with ankle fracture to walk in week 2 or not? I put a question to ask and say, is weight bearing in 2 weeks after ankle fracture fixation is effective and safe as weight bearing after 6 weeks or not? This is my question. Then you have to do a literature review. You have to go and search over the internet to see if anyone has searched about this question before and what is the results. Because if you have an answer to this question in the previous research, there is no point to redo the research. Then you study, you design your study, you do the way of randomization, you choose what is your treatment group, what's your comparison group, and for how long will you follow them up, and what is your outcomes you want to measure, and how will you publish the results. Then you have to get the approval because you're dealing with patient information and patient, you're doing some experiment on the patient. So you have to have the necessary ethical approvals. You start conducting your study, you come with a conclusion, and then you publish your results for all the people to follow you. The role of clinical research is to improve your patient care, definitely, because we're introducing new therapies, introducing new strategies, introducing new operations. It informs the healthcare policy because basically it makes, from the clinical trials, we make the guidelines, we make the policy decisions, and you innovate because with the clinical trial is the only way to apply new things in the science and see are they safe and effective or not. Like a lot of studies now, clinical trials now running about the AI to see if the AI is a safe option to use in the clinical practice or not, and how will we benefit from it. So to sum up for you, there is 3 quality projects: audit, clinical audit, quality improvement project or QIP or QIP, and clinical research. 3 of them aims to improve the quality. The audit improves the quality by making you compliant with the standards or guidelines. The quality improvement makes you improve your process and patient outcome. And clinical research is advancing the medical knowledge and introducing new ideas and treatments. Focus of the clinical audit is to compare your practice to a standard or guidelines. Focus of the QIP is to find your area of strengths and area of weaknesses. Focus of the clinical research is to ensure that you have an efficient treatment with new technology, with new treatment options. The method is clinical audit. You collect the data about your current practice and compare it to the guidelines. The QIP, you assess your practice, analyze it, and come with the area of strengths and weaknesses. The clinical research, either you observe or you intervene or experiment. Outcomes of the clinical audit is improving the practice based on evidence or guidelines or standards. Outcome of QIP is to enhance the care efficiency and safety. Outcome of the clinical research is new treatment, new innovations, new knowledge. The challenges you will face with everyone, there's nothing without the challenges, without problems, without difficulties. The difficulty with the clinical audit is time consuming. Sometimes after you come with the change and you ask the staff to do it, you find some resistance because they adapt to do this for years, and you're coming now to say to them, no, your practice is not following the standards or the guidelines and you have to change it. So sometimes you face some resistance. The challenges for the quality improvement project is difficult in maintaining the improvement because I check now my practice, I found some area of weaknesses, I improve them now, then I disappear. If I don't follow my improvement, at some point it will go back to the weak point again. So you have to keep doing it. And definitely you have limited resources, limited timing, and limited funding for that. Clinical research, the main problem is approval. because we're dealing with a human body. We do experiment or intervention newly on a human body. Imagine yourself asked to be involved in a study and they will try a new treatment or a new surgical technique on you. You will not be happy. That's why the most difficult point of clinical research is to get an ethical approval or ethical consideration. Recruitment and trying to get patient and convince the patient to be involved in the trial isn't an easy job. There a lot of administrative, a lot of financial, and a lot of support is needed for the research to be conducted. To conclude, the clinical audit, quality improvement projects, and clinical research are vital for advancing the care and ensuring a high standards of the NHS. Final thoughts is they have to start is hand to hand. You have to try to promote as much as you can of your patient safety. Health systems depend completely on audit, quality improvement, and research to improve the service, to save the resources, and to offer a qualified, safe service. And thank you so much. So time for questions. I'll stop the share. Good. We have a good number of questions. That's great. Okay. So Mohamed is asking firstly, how can I get an evidence for an audit I have done? So basically, if you have a full clinical audit team, it can easily get it as a certificate. They normally, after you finish your audit, submit your audit results, they give you a certificate. If not, you need to find a senior, you need to find a consultant. You have done the audit under his supervision, and he can give you a certificate that you have conducted this audit, you come with this change, and you re-audited what you did, and this is the results. So the way to get an evidence on your audit, either from an audit team, if you have an audit team in your institution, or through a senior who signed it for you. Mustafa is asking so in some hospitals in developing countries without a well-established protocols, which guidelines do you follow? So basically, Mustafa, is you have, as I told you, there's a lot of guidelines everywhere. The most and the well-formed established one is NICE guidelines, the British NICE guidelines, and for orthopedics is called POST, according to the British Orthopedic Association, standards of care for quality for trauma and orthopedics. You have the American Academy standards, and you definitely will find your seniors in every hospital in the developing countries are following way of this. So, for example, the diabetologist everywhere in the world, the endocrinologist everywhere in the world, if you are medical, they follow the Canadian, they follow Mayo Clinic guidelines, they follow National Health Institute guidelines from UK. So see what your seniors in the hospital you are working in using as a guidelines or standard. Try to audit the practice in your hospital compared to the guidelines or the standard they are using, and from here the audit will come. Mokish is asking, how can we find few simple practice guidelines on orthopedic specific patient? So basically, go write POST, BOAST, British Orthopedic Association Standards of Care for Orthopedics and Traumatology, and you will get all the guidelines for all the aspects of orthopedic practice. And same for American Academy, AAOS, American Academy of Orthopedic Surgery. And you will find very simple, practical guidelines on orthopedic specific patients. Can we have a hint about what it means, the audit? So audit basically is a comparison. So audit means you compare what you are doing to a standard, to a guidelines, to a standard of care. As I told you, very simple example, you in your normal life, you always audit yourself. How you audit yourself? You're doing a diet. So you should have 1,500 kilocalories or something like that. Like 40-50 grams of carbohydrate or protein or whatever. And you eat a lot, and then you come and calculate what you did eat, compare it to what you should eat or what is the normal requirements of an adult. And then you say, oh, I have eaten a lot, I've got a lot of calories, I should reduce that. This is an audit. Very simple. What did you do? You compared what you did or what's your practice or what's the way you have done compared to the standard, how you should done. So you compare what you do to what you should do. And this comes to say to you, are you following the standards or not? Simple way, your calories should be like 1,000 calories a day. After you eat, you go and calculate how many calories did you take. If you take a lot of calories, you reduce it. If you take less calories, you increase it. So basically, you're comparing the calories you are taking to the calories you should take. And this is exactly an audit. Same for any clinical practice. When comparing two intervention on two groups and comparing their outcomes, what did the study called? So basically, what you are comparing, you're comparing the outcomes. So this is a case control study. So as the example you're given an example of a distal tibia treated with plating or nailing. So what you are doing, you go to all the patients with distal tibia treated by nail and all the patients treated by plate. This is group number A. This is group number B. You follow them up for 10 years. And you come to say, oh, union rate in the group treated by plate was that. Union rate in the outcome, my outcomes is union rate. Union rate was like 80% in the people with fixed with nail, 70% in the people fixed with plate. So this is a case control study. You're comparing a group to a control group. And you come to say, oh, the results is plate or the nail is better than the plate because it achieves more union. How and where to register clinical trial? So clinical trials is different from country to country. So like in Egypt, I'm not sure in India, to be honest. I think it's with the association. So I'm a member of Bombay Orthopedic Society. So I think Bombay Orthopedic Society, they register clinical trials. I'm not sure what's your institute. In Egypt, you have to register it with the Ministry of Health. In UK, you have national health system, in the NHS, in NIHR, is a system to register all your clinical research, has a website. You go and register your clinical trial and you start do it. It is tough to register, definitely. It's not tough, it takes a long time because you have to give a lot of evidence for them to be sure that you're doing it ethically, you respect the dignity of the patient, you respect the patient information. Patient has been informed about the study, they understand that they will be exposed to a different treatment, they understand that their data will be going out as a publishment or whatever. So it's not tough, but it's difficult to take to get an ethical approval, and it takes a long time. Does audit need an ethical approval? Local ethical approval, Ahmed, means local ethical approval means you just get your audit team, your consultant, or whoever to say that, oh, okay, this is going with the ethics. Going with the ethics means you are not searching something. I'll give you an example. If you want to go and to audit something about sexual behavior, this will not be acceptable because this is an area of privacy. So if I'm your consultant, I will not agree on this audit to be done because doesn't follow the ethical. Some audit is going to compare patient based on religion, based on ethnicity, based on language. So all these audits are ethically not approved. I'm giving you just a easy example, like something which will never happen. But approval for audit needs to be just a local approval, either from your audit team, clinical audit team in the trust or the department, or from your consultant. Like I'm the audit lead. I'm the audit lead in my trust, so I approve all the audits run in my department based on what I can see. Audit is reasonable. It speaks about doesn't cause any problem, doesn't mix any conflict, doesn't go with any racism or bullying or problems like that. So just a local approval. In quality improvement, how can I know if I am in the correct path, not the wrong one? So there is in the quality improvement, there is no correct or wrong, there is no correct and wrong, there is no right and wrong. It's basically how you aim to see your practice. So I aim to see that no one of us will argue that we need to see a patient coming to the AD seen as quickly as possible, have the first aid immediately, and from the first aid immediately goes to the service which will help him, and from the service which will help him will have the operation or whatever treatment immediately. If I go and find that my patient is delayed in the AD for 8 hours, I'll have to go assess and see why the patient is delayed in the AD. Am I short in the stuff? Am I have a problem with communication? So there is no right or wrong. The point is, and you don't need to be comparing yourself to a standard. You compare yourself to the perfect. You're trying to have a perfect service. Perfect service means you're doing all you can to get the service to the best. So your aim from a quality improvement is to get your service to the perfect. So you don't compare to a standard. There is no correct or path or wrong path. The right path, the correct path is the perfection. You need to reach a perfection. And through your way to reach a perfection, you need to assess what are you doing, what is the problem, how to reach the perfection. This is a quality improvement project. Can we publish an audit? Definitely, definitely. Most of the research you see based basically on an audit. So the research idea starts from an audit. So when you audit, like I'll give you an example. So the documentation, the quality improvement documentation, the one I spoke to you about now, we are publishing it. We are publishing it to say, yeah, to see the results we came from the improving the documentation, making templates to our juniors, is that, and we show the people how to do this in their trust to improve the documentation, to make a standard orthopedic documentation. Same for the audit of DNA. We will be publishing our results of the DNA audit to say to the other people that people who do not attend the clinic mostly do not attend because of that. And when we done that, this has improved and patients are not DNAs again. So if you want to improve the attendance of the patient in your clinic, follow these rules, because we have done an audit which did show us that this is the way to reduce the DNA. So if you can follow this, you will reduce your DNA. So definitely an audit can be published, and the audit is basically the base of most of the research. Manish, you are Pakistani, don't worry, man. It's same here and there. May we receive a certificate of attendance? Definitely you will do. So once I finish, you will get an email for a feedback, and once you fill the feedback, he will send you a certificate. Thanks a lot. You're welcome, and see you in the upcoming. Yeah, we'll see you in the Congress next week. All the best, guys. We done. We on time. I hope it was useful, and you now have a clear idea what's audit, quality improvement, and research. Record will be in mid-all and will be on my channel on YouTube. I'm happy to receive any of your questions later on. This is my email address and email and phone number, and you are more than welcome to send me any question you want. Any one of you is interested in research, I can get him involved or her involved in research. And yeah. Have a good evening and night, and see you in another educational event. All the best, and yeah, wish you all the best. Bye.